sir, Dr. Inder has to go, so can he present? So Dr. Inder Rastogi, he'll be presenting on uveitis cataract, how to handle.
Good evening all. So cataract is most common complication in chronic uveitis, and the sequelae to chronic inflammation and chronic or topical steroid use. Incidence is around more than 50%, and it's the most common indication for surgery in such cases. So the type of the cataract is posterior subcapsular cataract, and poor outcome is because of inflammatory sequelae, structural abnormalities, and high rates of co-pathologies existing along with. So improved outcome has there in the recent time because of the proper patient selection and the biocompatible IOLs, improved surgical techniques, improved surgical capabilities, improved control of inflammation, and post-operative management of the complications. So outcome also depends on the patient age, risk of amblyopia, etiology, along with the clinical course of the disease and the pre-existing ocular complication, and of course the inflammation which is existing. In these cases, what are the indications? One is phacoantigenic uveitis, which is present along with, which is an absolute indication for this surgery, and visually significant cataract, which is there with the, of course, controlled inflammation, and where we want to assess the fundus. So there also we do the surgery, and of course where the cases which require pars plana vitrectomy. We have to put our attention to all these pre-existing conditions before we take up the case, especially from the cornea involvement up to the vitreous. So in these cases, we have to always ensure a two-step surgery, two-step management for the cataract surgery. Step 1, we have to control the inflammation, and step 2 is we have to control the post-operative inflammation also. We have to always pay our attention to the blood aqueous barrier, because after the surgery there is a lot of inflammation, and because of fibrin formation, we have to pay our attention to that also. So surgical procedure in these cases is a little bit complex, and it is a usually major challenge for the anterior segment surgeon, and intraoperative maneuvers with all these things which are there with the Sanique membranes and all that. So we have to use the iris retractor hooks. We should be very well versed with this, and sometimes because of the iris involvement there can be bleeding also, and vitreous haze and all that, they hamper the visualization. So these cases, these things which are there in this iritis cases, constricted pupil, that is become a challenge. So sometimes at the surgery we have to take decision of multiple sphincterotomies, bimanual stitchings with all these rings and hooks. So we have to take decisions, and of course the pupil size we have to increase up to 5 mm. We have to perform synecholysis, membranes are to be dealt with, and multiple sphincterotomy to be done. But at the same time, we have to take care of the anterior segment structure, so that the visual outcome is not hampered. Capsular axis has to be 5 to 6 mm, and if either it is a too small one, there will be problem peroperatively. If it is too large, unstable IOL. So ultimate thing is that you have to minimize the iris trauma in such cases. Steroids are must, and use of dye can be taken up depending on the situation, but these cases are to be done under block only. Phaco-chop is the best, that is to be done in the chamber, bag only, and we can use modified IOLs, but parameters they are to be kept to the minimum at the time of the phaco. So IOL material has to be acrylic or hydrogel. Implantation of the surface modified IOL, that will be taken up, or if uveitis is uncontrolled or less than 2 years of age, sometimes the IOL has to be deferred. So wrong way in such cases that we should always avoid AC IOL. Warning is that try to keep the posterior capsule intact if possible, and place the bag in the IOL, so that if the haptics are placed in the sulcus, that will lead to the further uveitis, and the problem will be there. So steroids are of much use into this, either oral or IV, or sometimes immunosuppressive medications are to be used. Cyclosporins can be used, And infliximab, they depend on the situation, what kind of the etiology is there. We can use that. Peroperative steroids are must. Preoperative steroids are must. We have to control the inflammation at least 2 to 3 months before the surgery. So in the immediate postoperative, we have to use frequent steroids. The frequency has to be much more, and during the night, steroid ointment has to be used. So successful outcome depends on the proper timing, proper control of inflammation, meticulous surgery, close monitoring, and advanced surgical technique. And immunosuppressive chemotherapy, if is advisable depending on the person profile, that can be taken up. So ultimately, dealing with this type of the cataract, fear, either forget everything and run, or face everything and rise. So if you face everything, you can have a successful outcome. Thank you very much.
Wonderful talk, sir, and very nicely given us a guidelines on how to manage the uveitic cataracts. And I would like to have a comment from Dr. Kapil, sir, for this. Any tips, sir, that you can
Absolutely right. Nothing to add to it. And maybe what I do in my cases in such cases is we prolong the use of topical steroids post-operatively for at least 3 months.
for
Usually we stop it at 20 days or 30 days.
Yeah.
In such cases, we prolong it for 3 months.
yeah.
So this is the only thing.
Thank you.
Thank you, Inder, for the nice presentation. I have a query, means if there is a uveitis with cataract,
Yeah.
and if cataract is responsible for uveitis, that means leakage of proteins and
Yeah.
then uveitis, any difference in management?
Sir, the management has to be take care of the the inflammation, control the glaucoma if it is existing, and do the surgery. If
Where lens is the culprit, should we wait for 3 months?
no, not at all.
Sir, in case
Otherwise,
there is,
yeah.
sir, in case it is uveitis with cataract, the thing we take care of first is uveitis, and we wait for the inflammation. If it is cataract with uveitis, we will take care of cataract only. The uveitis part will get taken care of simultaneously, except we might need to be more aggressive with steroids, including oral steroids.
Sir, I think one point is that if there is pre-existing uveitis, for example, patient of ankylosing spondylitis develops a cataract, the post-operative need of steroids or immunosuppressants will be there. But if it is a case of cataract causing uveitis, let us say phacoanaphylactic, then the cataract surgery in itself is the treatment of that case.
What will be the role of mydriatics post-operatively?
Thank you.
If you have a posterior capsular defect, that's what. So there is no posterior support. Which type of IOL would?
I think we can have a tuck. We can the haptic can be put in the bag, and optic can be there in the cell.
There is no support.
Sir,
Not
There
at
is
all.
no bag. No.
It has to be scleral fixation only,
I
and
think
whatever is
only
best in
scleral
your hand. Yamane, some people will prefer Yamane because it's very far away from the the scleral body. But whatever is best.
Yeah,
But
or a
definitely
glued
nothing
IOL
to do
also.
with iris.
Or a glued IOL.
Or